that did not look so good was surgeries, and I know that we are in the process of recruiting, and I know that recruiting physicians in every other single public hospital district has been really difficult.
And it is a costly organization, so I mean, whether it's recruiting or using locum tenens, it's expensive for our organization, so hopefully we can remedy that very quickly.
Yeah, it would be nice to have some stability there, not only for the revenue side, but for the people that we serve. It's nice to have a consistent group of people, because it's a consistent group of physicians and surgeons, hospitalists for people to be acquainted with. They're their friends and neighbors, so I think it's much more comfortable when we've got a stable group of physicians in, and I know Jerry's been, you've been working really hard at that.
Yeah, we are in negotiations for finalizing a contract with a general surgeon, but because it's not finalized, I don't feel totally comfortable in sharing any names at this point, but everyone is very excited about this opportunity, including the individual. I will tell you also that I was reluctant to change a lot in HR, knowing that I was bringing in a new HR leader, and I didn't want to put the team, have the team feel like they were going through a revolving door, that the CEO says this and now their new head of their department comes in and says that. But I did make the decision several months ago to work with recruiters on changing their scope of responsibilities to not only include recruitment, they now also have some key indices that they're responsible for retention as well. It's one thing to get docs here and ARPs and PAs, but to me it's even a more important role for them to play in understanding earlier what may be some of the indicators as to why they are choosing not to stay with us, and see if we can avert some of those when there are circumstances that are within our control. Obviously, some physicians have left because of personal issues, family issues, they don't like island life or whatever, but those physicians that may be leaving us because of something we could be doing differently, we need to identify those things earlier in the process and see if we can intervene. And Dr. Hansen and I have spent hours and hours of time discussing this, and I'm pretty sure he's in agreement.
Yeah. So. It's the same with you. It's nice for you to know who you're referring to or calling on.
And we've talked a lot about it, and really part of what Sherry's kind of brought to is involving the medical staff in interviews for these positions.
Is that a good idea?
Chief HR and other things. So it's been nice, and the medical staff sees that and appreciates the opportunity to have some input in these other areas that's going to affect us. So retention is big on our list.
And we have, on all non-physician positions that I feel have a significant impact on the physicians, we have physician leadership at the recruitment table as well.
Good. Thank you, Ron. Dr. Gibson, you're back with Dashboard?
Back with Dashboard. It's been a good bit of time this last month since we last chatted around the dashboard and looking at performance over the course of time in each and every unit. I would ask you to keep in mind that these are aggregate numbers that reflect a wide variety of scores in a wide variety of departments because they're aggregated. But for the past 5 months, and I realize it's difficult for you to read on this handout, but for the past 5 months, the top box scores for both nurses and physicians have increased over time, and it's really difficult to move top box scores. Even a percentage point is very difficult. It would seem simple, but when you look at it statistically, it's very hard. We do set high standards for ourselves, and with very low, very narrow parameters. For example, the parameter of physicians treat you with courtesy and respect, 94.5% is green, good, and 90% is red, which is bad. So you've got that literally, 4.5 percentage point top box scores, that the difference between exceptional and unacceptable. And we set those parameters early on because we want them to be achievable but difficult, and we want to be competitive, and we want our patients to tell us that we're doing a good job for them. The aggregated data, though, I look back at May 2014 through June of 2015. OB, for example, is in the 99th percentile on almost every metric. and with the exception of pain, and they've implemented a very targeted approach now to managing pain. Home health care is the 95th percentile in almost all of its metrics. ED ranges from 88 to 94th percentile, depending on the volume in the ED that month and the staffing levels. It's difficult when you aggregate them together. So one of the most important strategies to improve this is to really do very targeted, very unit-specific interventions based on the priority index for that unit. You know, when we brought Press Ganey in, Jerry was here, we brought Press Ganey in to educate all of our leadership team again about a little bit of the complexity of the statistical modeling behind Press Ganey, and to reassure people that this data may not be perfect, but it's the best that we have, and it's what we use, and we can compare ourselves to others using this data. But for example, what's important to a patient coming in to have a baby is different from what's important to a patient who's coming in for an outpatient visit to the ambulatory surgery area. And the priority index really tells us how highly correlated each of the parameters are to the likelihood that a patient will recommend the hospital and give the hospital a high rating. So if you look at the priority index for each unit where we measure, they're very, very different. So the solutions, I believe, in addition to what we've been doing, are to have very targeted, unit-specific interventions based on those priority indices and targeting those, in a very, very specific way. We're hoping that the Patient Advisory Council will help us. Patient Family Advisory Council will give us some insights that we might be overlooking with respect to that. And when we meet the first time in September, hopefully we'll get some of their feedback and insights. The hospitalist-specific interventions are we're collaborating with Sound Physicians. They're having a special meeting with Press Ganey, teleconference, talk about the physician components of this because we don't see them moving in that direction as quickly as we had hoped that they would, and as quickly as Sound indicated that we could expect that they would. So we're targeting some of their specific interactions and some of their specific opportunities for improvement. We are targeting, even though, as you said, the canoe and the dock analogy, if we do end up in a value-based purchasing world, eventually we're targeting having all of our parameters at the level where we would be favorably disposed if we were to move to value-based purchasing. So we've got both the patient aspect and the economic aspect to consider. If you look at the graphs, what you'll see too is a relationship between census and patient satisfaction. As the census goes up, the satisfaction levels change. And part of the intervention there is really to look at how people are utilizing their time and their efficiencies, and how do we continue with providing the same level of intervention and the same level of relationship when we're very busy, when we're much less busy, because the staffing is the same. So we need to look at our internal operating systems and make sure they're conducive to providing the best possible care and allowing us to do that, because when the census increases, which we hope it will and will stay there, because previously it had been pretty much full most of the time, we need to have some consistency in terms of those results and bring up the inpatient units, that core inpatient unit, to the same level as their colleagues are at this point in time in their patient satisfaction scores. The metric on turnover, I think, also has some influence on this, and that is that our goal, as Jerry mentioned, is retention, not just recruitment, because it is pricey to the organization when people turn over. But I think that the other way you reduce turnover and improve patient satisfaction is that you select people better and you onboard them well. And we have strategies in place for each of those things, with prophecy for selecting better and a modified onboarding process. It costs about 1.5 times a nurse's annual salary to recruit and replace a nurse in the organization. So it has an economic as well as a quality implication when we do that. When we look at turnover, though, we have a very low metric established, again, a goal for ourselves. If you look at the national turnover rates, for example, for medical surgical nursing, it's 24%. So the average annual turnover across the country for med-surg is 24%. Ours is obviously much less than that. The sad part of it is that 1/3 of all nurses who graduate from nursing school will change from the job that they enter the profession with in the first 3 years. And there are a lot of reasons for that, and that gets us back to the onboarding and the culture piece that we need so desperately to modify. But you have the strongest possible commitment from everyone. I see no one who's not taking this extremely seriously, and the accountabilities are there for improving performance on these metrics, not just because of the economics by any means, but because this is what our patients are telling us about how they feel about the care that we're providing. And it's important that we also look at how we compare to others. So the top box scores are important, but equally important is how do we compare to others in our Region 9. And we do very, very well, again, in those key areas like UD and home care and OB, but have opportunities for improvement in the other areas. So it is very targeted, very specific intervention on a unit-specific basis that I think is going to get us where we need to be to continue that progress. Any questions?
I think it's difficult. There's a lot of subjective answers to questions. And like we discussed, I think it was at medical or the MEC or somewhere, I don't remember recently, we were discussing that the fact that it's perhaps not the patient who's actually filling out the responses to the surveys all the time. So how do we touch the family members and let them know that yes, these services were provided, yes, doctors were there, and yes, nurses were in the room. So again, that may be something we can learn from other leadership teams with our counterparts.
And we are not the only organization striving to improve. So what happens is we make certain improvements, but if other organizations are improving also, we see no movement in our scores. Or if they are moving at a faster rate of change, obviously then we would actually slip. So that's part of the importance of understanding what your other colleagues are doing across the state and across the nation. And one of the things that we need to do a better job on is probably educating our patients and their family members about the survey process, why we do it, how we use the information we get back from them, so that it encourages participation. Because I'm as guilty as a lot of people that I get surveyed about everything I touch, it seems like these days. And how do you encourage people to actually respond to that survey at all?
I know, I think people are really tired of it. You go anywhere and you're getting a survey. But it's the only way that you can really, it's a good gauge for where you are. You still need that information.
Well, I just had I had one of those recalls on my car, and I took it in to get it taken care of, and I got a survey that gave me a sample of all the questions, and then it helpfully told me that only extremely satisfied would count. I thought, well, that's subtle.
Well, and I think
we're not allowed to do that.
The person filling out those surveys needs to realize that we're doing it for the benefit of our patients. We're not doing it just to collect data. We want to find ways and areas where we need to change what we're doing. So we're doing it for their benefit, and it's important that they fill them out truthfully and not just perhaps hand it to a spouse and say, what did you think about when I was in the hospital, honey? Fill it out. It's important.
Or children of a parent or something.
For children, yeah.
And to Commissioner Gardner's point, the survey, the way it's set up, the choices a person has really are never, usually, sometimes, and always. And the only things that count are the always, just like the only things that count.
And nothing is always.
And nothing, so if we have, the average person who comes to the hospital for 3 days interacts with about 50 people. If one of those folks isn't up to speed or isn't appreciated by that person, they don't put always. And most of our folks, you know, if you put together our usually and our always, we're way, way, way up there. That sort of contravenes the notion that only negative people fill out the survey, because most people think highly of us. It's just that there's that one person or that one situation that arose during their stay that was not to their satisfaction, so they can't put always. And that's what the top box scores are the always. And we have to get to the place where it's always.
Which is hard because you've got personalities involved.
Yep.
So, and patient personalities, not only staff personalities. Any other questions on the dashboard?